Hi, I'm Beth Battolino, CEO of Healthy Women. Thank you for joining us today on Healthy Women's first talk show, WomenTalk.
Hello and welcome to WomenTalk. I'm Rhonda Smith, the Executive Director of the California Black Health Network, and your guest host for this episode of WomenTalk. Today, we'll be talking about all things breast cancer. We'll be looking at what causes breast cancer, how to catch it early, important tests to know about, and what new treatment options are now available. We'll also be looking at how health disparities affect breast cancer risk and outcomes. And as a breast cancer survivor myself, this conversation is very near and dear to my heart. So today we're joined by two national breast cancer experts, as well as fellow breast cancer survivors. First, we have Dr. Kristen Zarfos. Kristen recently retired, lucky her, as the medical director of the Carl J. Krapek Senior Comprehensive Women's Health Center at St. Francis Hospital. And next is Lily Shockney. Lily is a nurse and professor of breast cancer surgery at Johns Hopkins University School of Medicine. Thank you both so much, not only for being here today, but for being amazing breast cancer clinicians and advocates. So let's get started with the conversation. Do we know what causes breast cancer and how to prevent it? Lily, do you want to take this one?
Sure. So this is still a work in progress around the world. We do know that being female certainly does place us into the 1 in 8 ratio of individuals that will be diagnosed with breast cancer. The causes, though, except for a few, are still unknown. 70% of women diagnosed with breast cancer have no known risk factors other than being female, which tells us that there's a lot of other causes that we've not deciphered yet. But that increased risk is associated with starting your menstrual periods younger, under the age of 12, and most little girls are starting now at the age of 10 or 11, which startles me as a grandmother. Also having a history of having gone through menopause late, and that's happening more and more also for women. Having had mantle radiation for non-Hodgkin's lymphoma as a youngster, a teen, or a young adult also is a known risk factor to increase this problem. And having a genetic mutation, which only applies to 5 to 10% of individuals diagnosed with breast cancer today. But if you do have one of those gene mutations, it really does jack up the risk. And then we look at doing prophylactic surgeries in order to really drop that risk as best we can. When we look at prevention, it's like, what can we do to not end up like the three of us, right? Having been diagnosed with breast cancer. Eating a healthy diet, low in fat, 30 grams or less, we do believe is a healthy way to approach life, and also reduce other conditions too, heart disease, diabetes, and such. Exercise, which doesn't mean you need a gym membership, but getting out there and walking is really our best exercise, and it's free. It doesn't cost us anything, and it's great if you can take some girlfriends with you, maybe. One of my girlfriends told me that she's now doing her steps at the shopping mall, but she's learned that she better leave her credit cards home. Yeah. And I'm like, uh-oh, that sounds like a good idea. Otherwise, probably going to have a financial problem to be added to that, right? Also, breast density is a new identified risk factor. And starting in the coming year, a breast imaging radiologist is going to be required to include that in your mammogram description of that report as to how dense are your breasts. Density does increase risk, and density shows up as being white. Well, we're looking for the polar bear in the snowstorm. We're looking for hopefully a tiny white object that's been identified as possibly being breast cancer.
I'm glad you brought up the density factor, because I forgot what state you're in, but in California, we have the dense breast law, right? And we know that for women with dense breasts, mammograms are not necessarily 100% reliable. and we definitely need a companion diagnostic tool or imaging
Mhm.
tool. So thank you for bringing that up. And I think there are a lot of women who are fortunate enough to have dense breasts. So, that's important to know that and have that conversation with their healthcare provider. I do have another question to follow up on the first one. And how do we catch breast cancer early? So you talked about some of the causes, but there's no surefire way to prevent breast cancer from happening, but there are some things that we can do to catch it early. So what are those things?
And that is our mission, is to find it as early as possible, because the earlier we find it in the majority of cases, the easier it is to treat and the higher the survivor rate is going to be. So when we do catch it early, 95% of individuals who are diagnosed with an early stage breast cancer are going to be long-term survivors. Long-term as in they're going to continue to live out their life with this being a bump in the road and not a derailment and not a dead end. So, clinical breast exam with your PCP and your gynecologist, and I do hope that all women are seeing both types of doctors. Breast self exam, though there's been controversy as to whether it's beneficial or not, I still do preach that this is important to do. No one should know your breast better than you. And though a woman might say, well, I've got a lump here and a bump there, and I don't know what it means, so it scares me, get to know your geography, your breastography, as I call it, and draw a little map for yourself. If I do have a little bump here and an indentation here, because what you're going to be doing is comparing your breast self-exam findings from last month and compare it to this month, because what we're looking for is a change. And the timing of when to do that breast self-exam should be a few days after your menstrual period ends, or if you're in postmenopausal state, then select the same date of the calendar for every month. My girlfriend told me, which she probably shouldn't have, that she does it when the gas man comes to read the meter, and now I'm wondering if he's probably helping her with her breast self-exam. I thought, very interesting that you chose it at that particular time. We also know that mammography annually beginning at age 40 is important to do. And again, we do prefer to have it be a breast imaging radiologist reading that mammogram rather than a general radiologist who may only be seeing a few mammograms, somebody that just lives and breathes breast cancer and breast health. A breast imaging radiologist is really ideal. It should be a digital mammogram, not analog on X-ray film, also known as tomosynthesis. And there may need to be some spot films done, and I never want a patient alarmed about that. It just means that they're being thorough. So the mammo tech might say, there's a little spot over here, we want to get a closer view. And don't like, oh, no, there must be cancer. No, it's probably a cyst. Could be nothing, could just be artifact on the image. And you really do want that thoroughness. As I mentioned earlier, we certainly do want to know what your density score is, what your density level is. And for those that have severely dense breasts, then there's probably going to be some additional imaging done. For those that carry a breast cancer gene mutation, they're also going to have additional imaging done. That could be ultrasound, but oftentimes it will be a breast MRI. The reason why breast MRI is not given to everybody is because health insurance will not pay for it for everybody. It's highly sensitive, but not specific. It finds the kitchen sink in your breast. So you can end up having to have more imaging done, which can make people, again, very nervous. But it is a good way to do a thorough assessment of your breast tissue. There's only one kind of breast cancer that we worry about that we are not able to find early through all of these imaging technologies and physical examinations, and that is inflammatory breast cancer. 3% of breast cancers are inflammatory. It shows up as a rash on the breast. And if you do have a rash and you haven't changed your soap powder or the bar of soap in your shower, something that would be causing you dermatitis, that type we need to investigate right away and do a biopsy of the breast skin, because just having a little bit of a rash, you're already staged as stage 3. So that's the one kind we have to act fast on. But the others, though, when you find out you've got an early stage breast cancer, I don't want women to have their hair on fire. You've got time to make good decisions, to see the right kinds of breast cancer specialists that can give you options as to how this will be managed, having all of the right types of tests done so that they can also figure out as a subset, what kind of breast cancer is this, and what are some of the features of this breast cancer that's going to guide us down the road with the patient as to what treatment modalities, what kind of surgery, whether or not she's going to need chemotherapy, if she's going to need hormonal therapy, if she's going to need radiation, and the timing of when to do all that. So don't panic and say, I've got to see a doctor by this afternoon and I've got to have my surgery by Friday, because you might not make good decisions. We have the opportunity to do this right once.
Great. So I want to ask a question about, breast cancer is a hormone-driven disease. And so when we talk about testing for biomarkers like PR, ER, and HER2, can you talk a little bit about what does it mean to test for biomarkers?
Sure. So the 3 most significant biomarkers, also known as prognostic factors, is the estrogen receptor, progesterone receptor, and the HER2 receptor. When we see that the breast cancer cells are estrogen receptor positive or progesterone receptor positive, both being female hormones, it tells us that your particular breast cancer is fed by female hormones. And that's actually a good prognostic factor to have, because we also know that that means it's relatively well behaved. And we have medications, anti-hormone therapy, to block the ability of estrogen in your body to reach a breast cancer cell, thus starving it. It also is used for prevention, these types of drugs, so that we could prevent you from getting breast cancer again. For those that are at very high risk and carry a gene mutation, they too may be placed on what we call hormonal therapy, the opposite of hormone replacement therapy. For those that are estrogen or progesterone receptor negative, they aren't able to benefit from these drugs. And that's frustrating for us and also frustrating for the patient, because we really do like to try to control this disease and prevent this disease with hormonal therapy. For HER2, this is an interesting prognostic factor. It's a specific protein on the breast cancer cell. And when we think about protein, we're not thinking about what we eat having protein in it. This is pathology cell structure. And if it's HER2 negative, that means that it is not overexpressing a specific protein called HER2. That also tells us, if it's negative, that it's better behaved as well. So we like hormone receptor positive, HER2 negative breast cancers. If it is positive, however, there's a set of drugs that is specific for HER2 positivity that we have patients take for a year. And they are in the category of what's called biologic targeted breast cancer therapy.
Great. Yeah. So let's talk a little bit more about that. I think what we're seeing more and more of is what's called precision medicine. So can you talk about some of the newer, I think what you're talking about is maybe been on the market for a while for the HER2 positive breast cancer, but what are some of the newer, more personalized drugs or targeted treatments for breast cancer?
Yes. So we're living in an exciting time where we're understanding the genomic health of your breast cancer cells, which is really important. Breast cancer just isn't one kind of cancer, is what we've really come to understand. There are thousands of subsets of breast cancer. As I just mentioned, 3 prognostic factors. There are also others that are in the gene category, where it may overproduce or underproduce a particular other protein And what scientists have been able to figure out to do is a patient who has this kind of a profile within their pathology, it tells us that this drug is going to work best for them, or this other drug probably will work best for them. I am personally particularly excited for individuals who have been diagnosed with stage 4 metastatic breast cancer that has traveled from the breast using the lymphatic system or the bloodstream and moved on to other organs in their body, most commonly goes to the bones, lungs, liver, and sometimes to the brain. And so we want to halt the growth and actually back it up, shrink it down in those other organs so that she can live in harmony with this disease. Not very long ago, somebody had stage 4. We were looking at a 1 to 2 year survival. And as a result of the development of CDK4/6 inhibitors, sounds like something we would blast off to Mars in, this drug classification for women's cancers that are metastatic and are estrogen or progesterone receptor positive and HER2 negative, it's actually giving these women the opportunity to live even 2 decades. I have many patients that have lived more than a decade on these drugs, and they are living in harmony with it, and they're accomplishing all of their milestones and life goals, and it's being managed as a chronic disease. But for those that are not with those particular prognostic factors, then it's not going to benefit them. The hardest to treat right now are triple negative for estrogen receptor, progesterone receptor, and HER2. So we primarily have to kind of stick with chemotherapy, which is a harsher therapy to try to get this disease to shrink, as well as prevent it from returning.
Yes. And so, thank you for mentioning triple negative. And just quickly, we tend to see that more in African-American women and women under 40. And you're right, it's more difficult to treat, but there are some therapies that are in the pipeline that will be specifically for triple negative breast cancer. So,
correct.
So
if I may just add one short little point for all individuals out there that may be diagnosed with breast cancer, or it's going to come up in their future, I want to make sure that you inform your treatment team of any milestones that are coming up in the next 9 to 12 months. Maybe you have a 25th wedding anniversary. Maybe your granddaughter is graduating from high school. Maybe your son is getting married. You want to make sure that you're not going to sacrifice those very significant milestone events to breast cancer. We need to dovetail your treatment plan around those milestones and not have you forfeit them. Don't let breast cancer have that much authority. You want to do what needs to be done to get rid of it or control it, and don't let it take away any more of that than needs to be. The same with your life goals. Where do you see yourself in a year, 5 years, 10 years? Really important to let your team know, because you are more than your pathology, right? You're a 38-year-old woman who's a 5th grade school teacher with a 9-year-old that has autism, and your husband left you last year, and you happen to have breast cancer right now. So putting all of that together so that we give you not just personalized treatment, but patient-centered treatment.
Yeah, that certainly gives you a different perspective on life for sure. So Kristen, let's go to you. How about, what is your perspective, or how should we think about breast cancer risk and outcomes as it relates to African-American women?
Well, I think it's very important that the audience knows, and both Lily and I, and you too, Rhonda, are very familiar with this data. I trained in Baltimore, where Lily is now. African-American women are diagnosed, a third of them, under the age of 50. And if you look at the guidelines for early detection, and we know early detection across all ethnicities has decreased the death rate from breast cancer by 40% since the 90s. A third of Black women develop breast cancer under the age of 50. And if you don't start a mammogram or every other year, you may lose the opportunity to find those cancers in an earlier stage. And why that's critical is that, as of SEER data, 49% of Black women are diagnosed with breast cancer when it's already spread beyond the breast. And we as survivors and we as caregivers know how critical that is. to
Right.
get a whole different kind of cancer to treat. Now,
You know,
part of it,
I was going to say, yeah, and I'm glad you brought that up because it becomes even more challenging, right? If it's triple negative breast cancer, which we see more often in Black women.
yes, we
So,
do, and triple
me too.
negative cancer is much more aggressive. I'm happy to say, thanks to the pharmaceutical industries and universities studying, we're finding more targets that can take it from being a very aggressive disease and taming it. I like to say taming it. But we have to find those cancers early, and we have to get young Black women in the door for screening to find their cancers before they're spread further, as it happens presently in 50% of women, and to engage those women in research, because so much of research is based on white women, and we need to have representative research from Black women. So the good news is many Black women, women of color, will have estrogen responsive tumors. And we know, again, because of all the amazing research that's been done, a lot of it at Johns Hopkins, all the research, we have targets on those cancers. But the new future for women of all ethnicities, but particularly for that 50% of Black women who are diagnosed with disease that has spread beyond the breast, that systemic therapy targeting some of the characteristics of triple negative cancers is so critical.
That's fantastic news. And so we anticipate that because of that now, there we will see better outcomes for African American women, and especially those diagnosed with triple negative. That's fantastic. So, yes, so thank you all, both Lily and Kristen, for being here and taking time out of your very busy day to share your knowledge and time with us today, and we really appreciate it. Thank you also to Healthy Women for the opportunity to be here to moderate this conversation with you all today, and great to meet you.